Hello everyone in CardioMinds channel and welcome to the third video on the guidelines of ventricular arrhythmias and sudden cardiac death. And today we are having 5 interesting clinical scenarios and how to deal with them. The 5 scenarios that we are going to discuss today are incidental finding of non-sustained VT, first presentation of sustained monomorphic VT, sudden cardiac arrest survivor, sudden death victim, and relatives of sudden arrhythmic death syndrome, decedents. First of all, there is a general recommendation that any patient with newly documented ventricular arrhythmia should have a first-line investigation at baseline 12-lead ECG to detect any features of underlying structural heart diseases or channelopathies. Recording of the ventricular arrhythmia on 12-lead ECG whenever possible, and an echocardiogram to exclude structural heart diseases. Then, if the patient is having suspected structural heart disease other than coronary artery disease, a cardiac MRI using gadolinium should be considered to confirm the diagnosis and risk stratify and to assess the extent of the scar. Let's have the first scenario, which is an incidental finding of non-sustained VT either on 12-lead ECG or ambulatory ECG. We used to consider non-sustained VT as a high-risk sign in ECG, but not in all cases. We need to look for actual high-risk features that may increase this patient's risk for sudden cardiac arrest, like recent syncope suspected to be of arrhythmic origin, polymorphic non-sustained VT, short-coupled PVC initiating the non-sustained VT run, and short cycle length like less than 300 milliseconds. All of these are considered high-risk features for sudden cardiac death, and so this patient may need hospitalization. Otherwise, this patient can be considered to be at low risk. Let's see this flow chart. If a patient is having non-sustained VT, we need to evaluate the ECG for the cycle length, morphology of the non-sustained VT, and whether it is exercise-induced or not. Then, personal history to assess for risk factors for cardiovascular disease, any symptoms, especially syncope, comorbidities, and what are the medications this patient taking. Then assess the family history for sudden cardiac death, any diagnosed channelopathy or cardiomyopathy, and of course check the lab, especially for electrolytes and BMPs and thyroid function. Then you need to ask yourself whether this patient has any high-risk features like arrhythmic syncope, fast monomorphic non-sustained VT, or short-coupled PVC followed by polymorphic run. If no of these features are present, so this patient needs just ambulatory evaluation and follow-up in the outpatient clinic. But if one or more of them are present, this patient would need hospitalization. He would need to have 12-lead ECG, formal echocardiography, and 24-hour or more Holter ECG to assess the burden of the VT and whether it is monomorphic or polymorphic through the 24-hour period. If all the features are suggestive of idiopathic origin, like localization of RVOT origin, ECG morphology suggestive of fascicular origin, negative family history, and normal ECG and echo, in this case you need to check the PVC burden. If it is less than 10%, so discharge the patient and just consider re-evaluation if he develops new symptoms or any change in his clinical condition. But if the burden is more than 10%, then in this case we are speaking about high burden of idiopathic PVC or VT, and we are going to discuss this later in a specific topic. If the patient is having features suggestive of structural heart disease in the ECG, for example, AV conduction abnormalities, pathological Q wave or wide QRS complex, ST or T wave deviations, abnormally high or low QRS voltage, polymorphic PVCs or non-sustained VTs, or in the echo, ventricular dysfunction, dilatation, hypertrophy, resting segmental motion abnormalities, or increased VA burden with exercise. In this case, we need to exclude coronary artery disease, and we would arrange for cardiac MRI to confirm the diagnosis of the baseline structural heart disease, and then further evaluation according to the most likely diagnosis. But if the clinical features are suggestive of channelopathy, then we are going to have a specific management according to the diagnosed type of channelopathy. So the specific recommendation for non-sustained VT is that they should have 24-hour Holter ECG, aiming to calculate the PVC burden, assess whether it is monomorphic or polymorphic, presence or absence of short-coupled PVC, and baseline ECG features suggestive of structural heart disease. And in this case, we can use a 3-lead Holter like V1 position and 2 inferior leads, which may help us to give an estimation of the site of origin of the non-sustained VT. We should not forget the exercise test, which can help to capture the 12-lead ECG of non-sustained VT and whether it is exercise-induced or not, as the increasing arrhythmia with exercise should raise suspicion of structural heart disease like dilated cardiomyopathy or ARVC, as it is not suggestive of idiopathic origin, and we call this adrenergic mediated PVCs, and it may need an advice to stop physical exercise till diagnosis and initiation of the appropriate treatment. The second scenario is a patient presenting for the first time by sustained monomorphic VT. The majority of those patients have underlying structural heart disease, and so the most common mechanism for VT is a scar-related re-entry, but occasionally it may be due to re-entry involving disease conduction system like in bundle branch reentrant VT, less common to be of focal origin due to abnormal automaticity or triggered activity. So the aim is to diagnose the underlying etiology and identify patients with idiopathic VT who have better prognosis. As we see in this diagram that we are asking the same questions like in non-sustained VT, checking the ECG for cycle length, morphology of VT and whether it is exercise-induced or not, personal history, family history, checking electrolytes, PMPs, and thyroid function. Then we are having 12-lead ECG and echocardiography from the start. If all the clinical features are suggestive of idiopathic origin, as we mentioned before, so we are dealing with a case of idiopathic VT, which has better prognosis. If it is suggestive of coronary artery disease as an underlying cause, so we would arrange for coronary angiography to exclude coronary artery disease, which would need a specific treatment. But if it is not present, so we would go for structural heart disease other than coronary artery disease, so we would arrange for cardiac MRI. We need to ask ourselves whether there is a suggestion of ARVC or not. If it is not suggested, we may need to have EP study and RV electroanatomical mapping plus minus biopsy, but if it is suggested, we would start specific treatment of ARVC. If there is suggestion of any other cardiomyopathy, it would need further evaluation according to the reached diagnosis. If there is suggestion of inflammatory disease like myocarditis, we would arrange for PET-CT, cardiac tissue biopsy, autoimmune serology, or mapping guided biopsy in case of regional ventricular involvement. If it is negative, so the further evaluation according to the most likely diagnosis. If it is positive, we would start a treatment for inflammatory disease, as we are going to mention later. So the specific recommendation here is that patient presenting with sustained monomorphic VT for the first time, EP study, electroanatomical mapping, and mapping guided biopsy may be considered to reach the diagnosis. And for the differential diagnosis between idiopathic VT and early ARVC, the guided biopsy via mapping can provide tissue diagnosis due to regional and focal distribution of the disease, especially in the early stages like in ARVC and cardiac sarcoidosis. This ECG shows monomorphic VT having left bundle branch block morphology with inferior axis due to the positive KRS complex in the inferior leads and transition zone in V4. This ECG suggests idiopathic VT, most probably in a structurally normal heart due to triggered activity, but we will need to have an echo plus minus cardiac MRI to exclude structural heart disease and confirm the diagnosis. But in this ECG, we are seeing monomorphic VT as well, but it is showing right bundle branch block morphology with superior axis as evidenced by the positive QRS complex in AVR and QRS duration relatively narrower. This suggests fascicular VT, which occurs in a structurally normal heart in young age. Re-entry is a mechanism involving posterior fascicle, or less common to involve the anterior fascicle, and it is sensitive to non-DHP calcium channel blockers, especially verapamil. While this ECG suggests bundle branch reentrant VT, as the antegrade limb is the left bundle branch and retrograde limb is the right bundle branch, which is common in patients with dilated cardiomyopathy, myotonic dystrophy, or after cardiac valve surgery. Now let's move to a more terrifying scenario, which is a survivor of sudden cardiac arrest. The first ECG feature that we look in the ECG after arrest is ST elevation, and this patient would need urgent coronary angiography to perform primary PCI and open the culprit artery. But if there is no ST elevation, in 3 randomized controlled trials, they showed no significant benefit for early coronary angiography post-arrest. However, in case of electrical instability after cardiac arrest and there is a suspicion for ongoing ischemia, in this case you need to go for coronary angiography. Let's see how to deal with a survivor of sudden cardiac arrest. Check the ECG after arrest. If there is evidence of ST elevation, go for urgent coronary angiography. If there is evidence of acute culprit lesion, so this patient needs to be managed as a STEMI patient according to the most recent guidelines. But if there is no culprit lesion, so evaluate the patient characteristics and the circumstances of the arrest, and of course arrange for echocardiography. If the patient does not have ST elevation, but he has features of electrical instability and suspicion for ongoing ischemia, go for urgent coronary angiography. Otherwise, just go for echocardiography. Try to exclude extra cardiac cause, as if there is a suspicion, go for brain and chest CT scan, and if there is an extra cardiac cause identified, so treat it accordingly. If there is no extra cardiac cause, collect the blood sample for toxicology and genetic testing and repeat and follow up the ECG. We need to have retention and storage of the suitable blood samples that allow subsequent diagnostic evaluation, including DNA analysis. If there is evidence of pre-excitation in the ECG after exercise or any suggestion for primary electrical disease, so treat it accordingly. And if there is pre-excited AF, we need to consider catheter ablation for the accessory pathway. If the echo suggests coronary artery disease or any other type of cardiomyopathies, so further evaluation is needed, and we need to have cardiac MRI with gadolinium to confirm the diagnosis. If there is suspicion of coronary anomaly, cardiac CT is needed to diagnose coronary artery disease or coronary anomaly. If they are present, they need a specific treatment. Otherwise, go for cardiac MRI to assess late gadolinium enhancement and the extent of scar. Don't forget that this patient needs repeated 12-lead ECGs during the hospital stay, including high-lead ECG for V1 and V2 to diagnose Brugada syndrome. If any primary electrical disease is diagnosed, so we need to have a specific treatment for it. If there is no evidence of primary electrical disease, but there is a suspicion for a specific one, you can go for provocative testing like sodium channel blocker test or exercise test. If there is suspicion of vasospasm, so you need to go for acetylcholine or ergonovine challenge test. If it is positive, so it is vasospastic angina causing the arrest. Otherwise, it is idiopathic VF, which is a diagnosis of exclusion. So the recommendation here is that the investigation of a survivor of sudden cardiac arrest needs a multidisciplinary team, not only a cardiologist. The electrically unstable patient after sudden cardiac arrest with suspicion of myocardial ischemia should have coronary angiography, and in survivors, a collection of blood samples at presentation is recommended for any potential toxicology or genetic testing, and retrieval of recording from any cardiac implantable electronic device or wearable monitors is recommended to be performed in detail for all survivors if you were present. The repeated 12-lead ECG during hospital stay, including high precordial leads to detect Brugada, as well as continuous cardiac monitoring, are recommended. Echo is essential. Coronary imaging and cardiac MRI with late gadolinium enhancement are recommended in all survivors if there is no clear underlying cause. Sodium channel blocker test and the exercise test is recommended if there is no clear underlying cause, especially if you are suspecting Brugada syndrome or long QT syndrome. CT chest and CT brain are needed if there is a suspicion of a non cardiac cause if all the investigations are not consistent with a cardiac cause, and ergonovine or acetylcholine challenge test or sometimes hyperventilation testing may be considered to diagnose coronary vasospasm if it is the only explanation. So what are your weapons to reach the cause of sudden cardiac arrest? Any ECG tracing from the emergency service in the ambulance or in any other hospital should be retrieved. Recording from the interrogation of any cardiac implantable electric device if the patient is already having an implanted one. Resting 12-lead ECG including high precordial lead and to be repeated regularly during hospitalization. Continuous ECG rhythm monitoring in the CCU or ICU. Blood sampling for toxicology. Exercise ECG. Echo, CT brain or chest, coronary imaging plus minus OCT or IVUS, cardiac MRI with gadolinium, provocative maneuvers according to your clinical suspicion, EP study and electroanatomical mapping may be needed according to your clinical suspicion, and the last thing, genetic testing also according to your clinical diagnosis to be decided by a multidisciplinary team. Then an unfortunate scenario is to interrogate a case of a sudden death victim who was not resuscitated in the right time. Why to investigate in this case? Genetic cardiac disease can be identified in about 25 to 49% of sudden cardiac death cases in the young population less than 50 years. And so, if it is a genetic disease, it may be affecting the relatives of the diseased person. And so, in autopsy, negative cases with negative toxicology, the term sudden arrhythmic death syndrome may be applied, as here primary electrical disease may be potential causes. So we need to know what is the reason for the sudden death to investigate the other family members. So if you are dealing with a sudden death victim, so we are speaking here about a deceased person, not a survivor, we need to check the circumstances of death, whether there were any symptoms or prior history of heart disease, whether there was any family history of sudden cardiac death before, or any family history of heart disease. Then comprehensive autopsy is needed and saving blood for potential toxicology testing, as here it is recommended in any case of unexpected sudden death and always in patients less than 50 years to include macroscopic examination of the heart, histopathological examination, and also of other organs if there is suspicion of non-cardiac cause. We have three possibilities here: either non-cardiac cause of sudden death, or sudden cardiac death of a non-inherited disease, or sudden cardiac death of suspected inherited disease, which is the one we are looking for. In this case, we need to save tissue for potential genetic testing. If we reach the cause, we would have targeted genetic testing and refer the first-degree relatives for cardiac assessment. But if the autopsy is negative, so we need to have toxicology testing to exclude drug overdose. But if the cause of death was not due to drug overdose, we need to suspect sudden arrhythmic death syndrome. If the decedent was less than 50 years or the circumstances of death or the family history is suggestive of heritable disease, so we need in this case to refer the first-degree relatives for cardiac assessment and to perform post-mortem genetic testing with genetic counseling, as here we are speaking about a different type from autopsy. That's why any unexpected sudden death, especially in case of suspicion of inherited disease, should be made a public health priority. We need to collect detailed description of the circumstances of death, symptoms prior to death, family history, and review any prior medical files. A comprehensive autopsy is recommended in all cases of unexpected sudden deaths and in all decedents less than 50 years of age to exclude cardiomyopathies or premature coronary artery disease. And in cases of sudden death, we need to have samples suitable for DNA extraction and consult a cardiac pathologist if there is a suspicion of inherited disease. Toxicology screening is recommended to exclude drug overdose. Genetic testing targeted to the cause is recommended if the cause of death is known or suspected to be heritable, and post-mortem genetic testing targeted to the primary electrical disease is recommended when we are dealing with a young decedent less than 50 years or the circumstances or family history support a primary electrical disease known as channelopathy. The post-mortem genetic testing for additional genes may be considered, but hypothesis-free post-mortem genetic testing as a routine using exome or genome sequencing is not recommended. Let's now see how to deal in detail with the relatives of sudden arrhythmic death decedents. We have three possibilities here. Either the decedent was not autopsied, but there are clinical features suggestive of heritable disease like young age, family history of sudden cardiac death if it was not the first time, or circumstances suggestive of heritable disease. The second possibility is that the genetic testing in the decedent was negative or not performed, but we have the same clinical suspicion. So in this case, we need to have familial evaluation in first-degree relatives or any relatives with suspicious symptoms. So first-degree relatives should be tested even if they are asymptomatic, including history, examination, standard and high precordial lead ECG, echocardiography, and exercise testing. If we reach a diagnosis, so we need to have more confirmatory tests, including genetic diagnosis, and manage accordingly. If there is no diagnosis reached, so we need to have ambulatory ECG monitoring and cardiac MRI to reach clinical and then genetic diagnosis. If no diagnosis reached, we may need to have sodium channel blocker test to diagnose Brugada syndrome or epinephrine test to diagnose long QT syndrome. If a diagnosis is reached, so we are going to start treatment appropriately. But if no cause is reached, we need to follow up the children of the decedent till they become adults, and if the adults are asymptomatic, so just discharge them from the follow-up and the investigations. The third scenario is that in the decedent we identified the pathogenic mutation. So now we know the cause, so no need for all these investigation. We just need to evaluate the first-degree relatives or the obligate carriers. For example, if we are speaking about an autosomal dominant disease, so I know that the children of this diseased person should have the abnormal gene or relatives with suspicious symptoms according to the condition. All these family members should have genetic counseling and cascade testing for the relatives, as we know the cause that we are looking for to reach a clinical or genetic diagnosis and manage the relatives according to the condition. So this makes, of course, a pathway much easier. So the familial evaluation is recommended for first-degree relatives, any relatives who must carry a mutation based on the analysis of the family history that we call obligate carriers, relatives with suspicious symptoms, if the decedent's age was less than 50 years or there were circumstances or family history suggesting heritable disease, and the familial evaluation should include genetic testing if the post-mortem genetic testing in the decedent detected a pathogenic mutation, so we should look for this mutation in the family members. If there is no genetic mutation detected in the decedent, so the baseline familial evaluation should include medical history, examination, standard and high precordial lead ECG, echocardiography, and exercise testing. And in families without a diagnosis after a clinical evaluation, the follow-up is recommended for the children of the decedents till they reach adulthood, as there is a phenomenon called age-related penetrance, as this child may have the abnormal gene, but he would not manifest the phenotype of the disease till he is or she is adult. That's why you may need to have regular follow-up every 6 to 12 months. Pharmacological testing using a sodium channel blocker like agmaline or flecainide is recommended in the family members who are more than or equal 16 years if the baseline testing or the proband findings suggest Brugada syndrome. Ambulatory ECG monitoring and cardiac MRI may be considered, and the pharmacological testing including epinephrine challenge or sodium channel blocker challenge may be considered in the first-degree relatives even if all the testing was normal. And the big no here is that in sudden arrhythmic death syndrome families without a diagnosis after all the clinical evaluation, follow-up is not recommended for asymptomatic adults, as they can be discharged with advice to return if they develop symptoms or the family history changes. For example, another one died suddenly, but in the children they need regular follow-up due to the age-related penetrance. So after we finish this difficult 5 clinical scenarios, we reached the end, and our take-home message is that you have a large number of tools that you can use according to the clinical suspicion or the cause, as asymptomatic patients with non-sustained or sustained VT, survivors of sudden cardiac arrest, or the sudden cardiac death, decedents, and their families. So take your time to think of the useful and appropriate test to choose based on your clinical diagnosis and suspicion. Thank you very much for watching this video, and wait next week for another video in the guidelines of ventricular arrhythmias.